Hello, everyone. So here I'm going to talk about the COVID-19 treatment. So this is COVID-19 treatment simplified. Is World Health Organization wrong on recommending no steroids in COVID-19 right from the beginning? I'm Srikanth Ramachandruni. I'm an infectious disease specialist in the state of Texas. So as you can see over there, the case fatality rate as of May 22nd, 2020, it's anywhere between 3 to 9% all over USA. The state of Michigan had 9.5% case fatality rate, whereas state of Texas has about close to 2.7 or 3%. And overall case fatality rate in USA is about 5.9%. In Nueces County, Texas, we have total cases 260, and we have three deaths, and the case fatality ratio of 1.1%. So how did we do that? First, I'll go through the mechanisms, the COVID-19 postulated mechanism of actions. So the COVID-19 can cause viral pneumonia and also can cause multi-system blood vessel endothelial inflammation. That means it can affect the endothelium of the blood vessels, but the blood vessels go everywhere, to the lungs, to the heart muscle, to the pericardium, to the brain, to the kidneys, and so they can cause widespread blood clots. It's in the lungs and it's in the legs. We call DVTs. So while the virus is multiplying in the body and affecting and attacking the blood vessels and the lungs, the body also tries to mount an inflammation response, which it recruits some C-reactive proteins, D-dimer, ferritin, LDH. All these are the inflammatory markers that go up while the body is trying to mount the immune response. So these markers recruit the cells that make antibodies that will neutralize the virus. So these are very important to measure, so we can objectively measure how much the body is reacting to the virus. So the next one is we can also see the imaging findings on the CT chest, the CAT scan of the chest, and the chest X-ray. The classic changes where both lungs show bilateral white opacities. That is how we diagnose the COVID-19, and it'll kind of show from the rest of the pneumonias, it is kind of classic peripheral opacities on both lungs. So the improvement, I want to show it in real numbers. So the following slides will display the imaging, the oxygenation numbers, and labs objectively. So that means the oxygenation numbers is we give oxygen to the patient in terms of nasal cannula, 2 liters, and then we go up slowly and gradually to 3 liters, 5 liters, 10 liters. And then once we run out of that, we go to high flow oxygen. That means we pressurized oxygen at 10 liters, 15 liters, 50 liters with a high concentration oxygen. After that, the next step is, of course, non-invasive ventilation, which is a mask ventilation. The other last step is, of course, the ventilation, the intubation. So I will go to the first patient. You can see this is a normal lung CAT scan. Both lungs are very well aerated. You can see the black air in the both lungs. So as you can see here, both lungs show white opacities. So what that means is the COVID-19 starts affecting the lungs. It could be a virus causing the damage or the inflammation causing the damage. One of them is causing severe damage and the patient starts feeling a little short of breath. That means the patient starts requiring oxygen support where you to maintain the oxygen levels in the body, which is measured by pulse ox. So they have to keep the oxygen levels above 90%. We start supplementing oxygen. So we start supplementing oxygen by means of nasal cannula, which is through a tube in the nose, right? So 2 liters, 3 liters, 5 liters. We go up as the patient requires the oxygen support. But these guys are happily hypoxic. That means they don't feel it till they crash. The first few days, they start requiring higher and higher oxygen support, but they feel good about not feeling, short of breath, and they can walk a little bit. They feel short of breath when they walk, but otherwise when they're resting, they're fine. So this is something to keep in mind. Whenever they're hypoxic, that means the inflammation started already acting on the lungs. So here, some of the this is the screenshot from the hospital oxygen requirements on this particular patient. As you can see, the patient was hospitalized between May 3rd and May 12th, and he was on room air initially, and then we had to go up on oxygen support. And I will summarize this here. On May 3rd, he was on minimal oxygen support on nasal cannula. On May 4th, again, same thing. And then he started deteriorating. This is when they crash suddenly and they go on non-rebreather. For the next 3 days, he was on high flow oxygen and higher oxygen support to maintain the SATs. But on May 8th, we had to intubate him. He was on ventilator support for 2 days. And then something happened, miracle. So on May 10th, he's back. He's off ventilator. He's back on the venti mask. So the duration that he required this oxygen support was less than few days, maybe less than 7 days. And the inflammatory markers that I'm talking about, the CRP and D-dimer, as you can see, on May 8th, it was 38, and then it started going down rapidly to 2.2 on May 14th within 7 days. And the D-dimer, as you can see there, 2,166, it went down to 1,200. So, and then the next patient, you can see the same findings on the CAT scan. You see the bilateral white opacities, which is very characteristic of COVID-19. And also here the oxygen requirements of the patient. He started out on May 9th with 4 liters, and then it had to go up to high flow oxygen, where we had to give him 45 liters, and then went up to almost 60 liters. And I'll summarize this in the next slide. So by May 16th, May 19th, he was back on 3 liters of oxygen. So that means within, again, same thing happened within about 7 to 8 days, he started improving on the treatment. The CRP levels also went down rapidly here from 97 to 4.7 in about 7 to 8 days. And the D-dimer here you see from 2,100 went down to 1,100 in the same duration. So the next patient, you can see the chest x-ray. This is a normal chest x-ray. It looks nice and black on both sides. And here the COVID-19 chest x-ray, you can see the white opacities on both sides. And again, here the oxygen requirements of the patient. This is a screenshot from the medical record. And you can see on April 15th, he was on 3 liters. And then we had to go up again to almost 60 liters. And this is a summary of that. On May 15th, he was on minimal oxygen support. And then from May 16th through May 21st, he was requiring higher and higher oxygen supports, like almost to 60 liters. And then gradually, we were able to wean it down to 3 liters within about 10 days. And the CRP markers are also went way down. This is the best measure for the inflammation. That means the amount of response our body is mounting against the virus. And you can see the CRP going down with the treatment nicely to 12.7, and the D-dimer also from 863 to 406 within few days. And this is the next patient. You can see the same findings in the chest x-ray, white opacities on both lungs. And this patient was intubated. That means he came right into the hospital and had to be put on ventilator support. And he was on ventilator support only for 3 days. And then he came out of the ventilator and he was on nasal cannula. So within few days, he improved. And again, the same thing, the CRP went down from 206 to 1.9 within few days. And here his D-dimer went up to almost 17,000 and then came down to 1,522. And the next patient, same thing. This chest CAT scan shows white opacities. And the oxygen requirements, as you can see, he never had to go up. He just, I think he required only 4 liters. Eventually, he was weaned off to 2 liters of oxygen within about close to 7 days. The same thing shown here, a summary. He was requiring initially 2 liters and then went up to 4 liters and came down to 2 liters. And the CRP here is 216 and went down to 26, and D-dimer is also going down here. And the next patient, similarly, we have the CAT scan findings. and the inflammatory markers, they are improving on the treatment. So what's the trick? So this is very key. Key thing is to start treatment on day one. As I said, these patients are happily hypoxic. What that means is if you delay for a few days and they crash and they go on ventilator support, and it is very difficult to get them back. No matter how much you try, sometimes it's futile. So it's important that you try these treatments on day one, even though the patient is saying he's doing better, but he's requiring oxygen support. That's the key indicator to start the treatment. What are the modalities? One is, of course, you attack the virus. The other one is you attack the inflammation. Our body overreacts and damages our own tissues like lungs and heart muscle and whatnot. So you need to dampen that inflammation, and also you need to kill the virus. We don't have any drugs at this moment that will kill the virus effectively. We have remdesivir. That the response is kind of mixed, but the best treatment, of course, is the convalescent COVID-19 plasma, which is nothing but the patient recovers from the COVID-19. He already might have developed the antibodies that will neutralize the virus. So we take that plasma and give it to the sick patient. So that's what the convalescent plasma means. So step one is methylprednisone, which is a steroid that we give to dampen the inflammation, which is 40 milligrams. We give every 12 hours. We give 8 hours, every 8 hours, depending on if they're very obese, then we increase the dose. We started, as I said, as soon as they get hypoxic. That means they start having to need oxygen support. How long do we give IV steroids? Most of the studies show we have to give only short duration, but the problem is once you stop steroids, they go back. So it's important that you continue the steroids and start tapering once the inflammatory markers, that is the D-dimer and CRP, once they're normalized, then you can start tapering the prednisone. And the step two is convalescent COVID-19 plasma, which is again as soon as possible. Our patients received the convalescent plasma within 24 hours, so they had a good improvement with the steroids. And how much do we give? 400 ml, which is ABO compatible. And how many times? Usually we give it only once, but sometimes we had to repeat a couple of times. There are no side effects to the plasma. Step three is, of course, this is a blood vessel endothelial inflammation. So in order for the blood to flow freely, we give heparin 5,000 units sub-Q every 8 hours or 6 hours. This is a blood thinner. We give it at low doses to prevent the blood clots. But if the D-dimer is super elevated, then we give at higher doses as if the patient has blood clots. We cannot check it out because he's COVID-19. So if the D-dimer is elevated, that's an indirect indicator that the patient might be developing small blood clots that we cannot see with the imaging. So we go ahead and give higher doses of blood thinners. Our stats, we have several COVID-19 patients admitted to the area hospitals, out of which within 24 hours of admission or diagnosis, 23 patients received this combination treatment of steroids, convalescent plasma, and the blood thinners, anticoagulation. So all survived, and everybody went home within 7 to 10 days or stabilized within 7 to 10 days. So earlier in the course of the pandemic, 2 patients did not survive because we couldn't give the treatment, the above treatment early on. Did we use any other treatments? No. Can we use remdesivir? Absolutely. If you can get it, why not? The idea is for the patient to have a fighting chance to survive for the first 7 to 10 days, so until he or she can develop their own antibodies that can fight and neutralize the virus. So you have to give them first 7 to 10 days. These are the references. The first one is my paper, and the second one is from the Henry Ford, who have observed the steroids help these patients. It's a study of about 200 patients where they showed improved mortality and oxygenation requirements. And that's it, folks. These are our treatment experiences only. So use it at your own discretion. Thank you.